to talk about today is going to be about iron metabolism. So we're going to start discussing a very comprehensive discussion of a big topic. The big topic is going to be anemia. And we are going to go and start talking about anemia today and several classes from now on until we are done with the red blood cells. And then we will move into the white blood cells. So, what is anemia? Can anybody give me a simple layperson definition of anemia? Okay, yeah, but the bottom line is going to be whenever you are having low red blood cell counts, that's going to be translated in this condition that we call anemia. Anemia is not a disease by itself. Anemia is a symptom of other diseases. Okay? When you are going to have low red blood cell, it's going to be translated into what? You're going to have low hemoglobin. It's going to be translated into you're going to have low hematocrits. So all the above is going to be, basically characteristics of anemia. Low red blood cells, which is going to be low hemoglobin, and is going to be low hematocrit. I have some important information that I want to tell you if I forget, because I usually tell that in the laboratory and I forgot to tell you. This is one of those things that you learn now and you remember it for the rest of your life, okay? And that's going to be the rule of 3. Okay? It's a very simple rule. But this is one of those things that I always tell you when you're going to begin working in the workplace, actually reporting the result of the patients, you always got to remember the rule of 3. Because there is a relationship between the red blood cells, hemoglobin, and hematocrit. Usually, not exactly, usually approximately, there is a relationship of 3 folds. So if, let's say that if my red blood cell is 3.0 times 10 to the power of 12 per liter, I can tell you that my hemoglobin is going to be very close. If everything else is fine, there's no other thing going on in here, it's going to be 9.0 gram per deciliter. And I can tell you that my hematocrit will be 27%. Okay? Now it might be 26%. That's okay. It doesn't have to be exact, but it approximates. There is a relationship of 3s. So if you are going to go ahead and report the results that is coming out of the machine, and you're going to be able to see that, all right, this person is going to go ahead and have the red count of 3.0, okay? Is going to have the hemoglobin of 15, and is going to have the hematocrit of 27. There is something majorly wrong with this result. You should not report this result, okay? You should make a slide, and you got to look at the smear, and you got to find out what's going on. What's the problem with this one? 3 times 3, 9. Why is this 15? I'll tell you why it is 15. Because this person has hemolytic disease. His or her red blood cells have lyse. Whenever you are measuring the hemoglobin, you measure the hemoglobin inside of the red blood cell, but you also measure the free hemoglobin in the plasma. Usually you don't have much there. But in the case of hemolysis, you will have a lot there. So that's what it is. The person is not going to have the red blood cell because they lyse. The person is not going to have the hematocrit because the red blood cell have lyse. However, the hemoglobin is going to be indicative of much higher number. So it is a very important, simple rule that you got to keep that in your head. There's a relationship of 3s, factor of 3 between red blood cells, hemoglobin, and hematocrit. So when your exam comes up in a couple of weeks, if I give you a case study and I'm providing you with the results, keep that in your head. Keep that in your mind. You're going to use that in order to be able to solve a lot of things. Okay? All right. Rule of 3. So iron is going to be a very important component, is an essential element. It means that we have to get it in our food. If we don't get it, we're going to have a lot of problems. But many of you may think that the iron is going to be necessary for the hemoglobin. That's true, but that's not going to be all. You need to have iron for things such as myoglobin. Myoglobin is a relative of hemoglobin that is going to store oxygen in the muscle. Okay? We have already briefly talked about that. It's going to be able to store the oxygen in the muscle. So whenever you are using your muscle, the muscle is going to require a lot of oxygen. It's going to get it from myoglobin. Iron is also going to be an important component of enzymes that are going to be inside of the mitochondria. Enzymes such as cytochrome B. There are going to be enzymes in the electron transport chain. They have a core iron. Without that, they're not going to be able to conduct the electron transport chain. However, about 75% of the iron in your body is going to be found in the hemoglobin. Okay? In the hemoglobin. About 25% of the iron, not 20, that's too much. That's that. I would say about 15 to 20% of your iron is going to be stored inside of the cells in a form, we call it ferritin. So ferritin is a macromolecule. It's a molecule, okay? It's a macromolecule. Without having any kind of iron, we call it apoferritin. When the iron becomes stored in this macromolecule, we call it ferritin. On average, you will have something about, I don't know, I don't think anybody has sat down and counted actually the number of iron molecules, but something around 2,000 to 4,500 iron molecules are going to be stored in each ferritin inside of the cell. Okay? There are a lot of small things here that you need to pay attention. Now, if you want to take a note of those things, those are the things that you should take a note of. One thing is going to be this, because I want to tell you, because if I don't tell you right now, I'm going to forget. Ferritin, where are you going to find the ferritin? In the cell. In the cell. However, we are able also to measure the ferritin in the plasma. Why? There is a spillage of the ferritin from the cells into the plasma. It's not going to be as much ferritin in the plasma as we have inside of the cell, but there is a relationship between the ferritin in the plasma and ferritin inside of the cell. If you have a lot of ferritin inside of the cell, your ferritin in the plasma is going to go up. If you don't have as much ferritin inside of the cell, your ferritin is going to go down. That's going to be a very important diagnostic tool. Remember that. So when I tell you that we measure the ferritin in the blood, that's what I'm talking about. Okay? I'm not talking about the entire ferritin in your body. I am just talking about the ferritin that is present in the plasma, which is going to correlate to what is going to be inside of the cell. Alright? Another thing I want to tell you before I forget is iron there are two forms of iron. We have already talked about this briefly, but let's go ahead and talk about it one more time. It's important. You're going to either have the ferric iron or you're going to have the ferrous iron. Ferric iron is going to be 3+. It's oxidized iron. Ferrous iron is going to be 2+. Is reduced iron. Fe2+, the ferrous iron, is like a teenager. It's like a teenager with a lot of money in his pocket. It's like a teenager with a lot of money in his pocket and a very rich daddy and a good lawyer. What is going that do? It's going to cause a lot of problems, right? And that's what this iron will do. What it wants to do, it oxidizes everything. It will bond to everything on its way. If you find it like this inside of the body, it's going, for example, oxygen. Iron, you know there is iron in the hemoglobin, right? And you know that oxygen is going to bound to the hemoglobin, right? If you are going to go ahead and have this free iron is the key, ferrous iron, you will have, plus oxygen, you will have a compound called superoxide. It's going to be, this can bind to your DNA and oxidizes your DNA. Your DNA is going to go out of commission. This can bind to your cell membrane, it's going to oxidize your membrane, your cells are not going to be able to change their shapes. This is a nasty stuff, you've got to get rid of it. So what is the best way of getting rid of these kind of things? Is you make sure that you're not going to have a free iron like that anywhere. So the iron that we're going to be able to use in the hemoglobin has to be like this. But whenever we're going to absorb it, we cannot absorb it like this. Whenever we're going to transport it, we cannot transport it like this. We have to do it like that. So there is going to be this transition between Fe3 plus, the ferric iron, and Fe2 plus ferrous iron continuously. Anytime that the iron is going to be stored in the ferritin, it's going to be ferric. Okay? It's going to be ferric. If you are talking about the iron inside of the hemoglobin, it's going to be ferrous. If you are talking about iron moving from point A to point B inside of your body, it has to be in a ferric state. Ferric state. You don't want iron cannot by itself go from one point to another point. It has to have a carrier. It has to have a transporter, and that's what it does. There is this protein, we call that transferrin. Transferrin, this is my version of it, and there is no resemblance to actual molecule. I want you to know about that. This is transferrin. T is going to be able to carry 2 irons, both of them in ferric state. Okay? Everybody, any questions so far? So if I want to go ahead and absorb the iron from the food that I ate, I am going to go in and have the iron in my guts in a ferric state. If I want to absorb it into the cell, I have to turn it into ferrous state. But when it comes to the cell, I got 2 things to do. Either I can store it inside of the cell, I have to make it ferric. Or I can send it out to the blood. That's going to be a little bit more complex. It's going to go as a ferrous into the blood, but before it gets bound to the transferrin, it's going to be converted to the ferric. So transferrin is going to be able to take the ferric iron in its oxidized form, so it does not bound to anything on this path. And it's going to go, and the cells such as the pronormoblasts, such as the precursors of the red blood cells, guess what? They have a receptor. They got a receptor for what? They got a receptor for transferrin. So if the cell has a receptor for transferrin, this transferrin with these 2 irons is going to be able to get stuck here, and then this is going to get endocytosed, and it's going to ultimately result in the release of the iron. You're going to have the enzymes there. Those enzymes are going to reduce the iron into the Fe2+, and that iron will be used, sent to the mitochondria, be used in order to make the hemoglobin. Okay? Now the food that we are eating has usually in this country, in the United States, our food is fortified. Every time you're eating cereal and things like that, the food is fortified with iron, okay? But you gotta watch out. This is a very tricky thing in here, because we're gonna this is the problem, people. Too little iron is gonna cause problem. Too much iron is gonna cause problem. And the problem is that our body, mammalian bodies, not just ours, our body specifically, because we are talking about humans, does not have any means of getting rid of iron. Now there is a dilemma. If you are going to have too much iron, you're going to get disease. Or you're going to have too little iron, you're going to go ahead and get disease. And if you want to get rid of the extra iron, you have no means, there's a problem. What do you think would be the best way and easiest way to control the amount of the iron in the body? You cannot do it. You don't have mechanism. You got to control the absorption. How much you want to absorb. That's going to be the key. Because in our diet, as I told you, we're going to have enough iron. You should not be running out of iron in our diet. You usually have something about 15 15 to 20 milligrams of iron per day in our food. Sometimes more, depending on what you're eating, of course. Sometimes less, but on average about 15-20 milligrams. We're only going to absorb 1 to 2 milligrams per day. Hold on. If you're going to continue absorbing 1 or 2 milligrams per day and you have no mean of losing that iron, it's going to add up. There is one way that we can go. Of course, the other ways you know that. If you're bleeding, you're going to lose iron. Okay? That's why females that are premenstrual, they are going to, premenopausal, they are going to need 50% more iron than men. That's why if you are taking multivitamin, guys, you got to look at the back of that container. If there is iron in it, you should not take it because you are not losing blood unless you are donating blood on a routine basis. Then that's another story. Otherwise, if you are taking extra iron, it's going to come and haunt you in 20, 30 years. You're going to have cardiac failure, you're going to have diabetes, and all those diseases are going to happen because of iron toxicity. These are the things that you have to take into consideration. I would not say the same thing about the female who is 20 years old and is taking a multivitamin with iron in it. She should, because by menstruation you're going to lose iron every month, so you got to increase the supply. Another thing. So let me convey an idea for you, because I have talked to, I enjoy talking to you folks when you come and talk to me in my office. I really enjoy it. It's really fun. And I can see what is going on in your head, so I would be able to help you out. If you don't talk to me, other than what the heck is going on in your head? Sometimes I wonder. So what it is that you always got to see who is on the other side of this result. You cannot look at the number or look at one cell and decide what is going on. You got to look at the whole picture. I've told you many times. For example, if you are having a kid, 5-year-old kid, you would expect the iron level to go up. You expect the diet to go up. You expect a higher supplement of iron for that kid. Why? Because the kid is growing up very rapidly. It's making more cells. It's making more muscles. Muscle needs more iron. Red blood cells needs more iron. So the demand for the iron for a child who's growing up is going to be much higher than an adult like me. If a woman is going to be pregnant, she's going to take the iron for herself, but she has to take the iron for the fetus as well. So she's going to have a higher demand. If a woman is breastfeeding, she needs to take more iron. She needs to make a lot more iron than she usually needs if she was not breastfeeding, because the iron is going to be supplied to the baby, to the breast milk. So you got to think about who is on the other side. What is the situation in order to determine whether or not this person's iron is sufficient or not sufficient, okay? And remember, this is just one of those trivial information. When you're eating the cow's milk doesn't supply iron, okay? Just be aware of that. If you're having a, if for whatever the reason of mother's breast milk, there is no replacement for mother's breast milk. I tell you this. We will discuss that later on when we get to white blood cells why. However, if you are having, but sometimes there are conditions that you cannot do it. It's not just possible, it's not feasible. That's fine. And they replace, some people replace it without consulting with somebody, a physician or somebody who knows what's going on. They give them cow milk. And those kids will become iron deficient. And they develop anemia because cow's milk doesn't have iron. Okay? So be aware of that. Soy milk will have it, almond milk will have it, but cow's milk does not have enough sufficient iron for the growing child. Okay? Alright. So dietary iron, you're going to be able to get it both from meat as well as from plant-based. But there is this thing about it, about 60% of the iron that we are absorbing is because plant-based. About 40% is going to be coming from the meat. But again, you guys realize that it's all going to depend on what you're eating. If I'm a vegetarian and I don't eat meat, my 100% is going to come from the plant. So you guys put these things in perspective, okay? But the thing is that somehow the heme iron, the iron that is attached to the heme, which we mean that is coming from the animal source, is easily absorbed versus comparing to the plant iron. The plant iron is not as effective, okay? But the meat iron is going to be more effective, okay? So just be aware of it, that there is going to be not the same rate of absorption of the iron. All right, what else we have up here? So I'm going to talk about that storage I told you. Primarily case is going to be the ferritin, that you're going to be able to store the iron. You would be able to store the iron. But I forgot to tell you one thing, and that thing, you know what it was? It was this. How can we lose? So the idea was that we are absorbing 1 to 2 milligrams of iron per day. If we don't get rid of 1 or 2 milligrams per day, over time, this is going to build up and it's going to cause toxicity. You with me? Okay. Remember that beautiful lining of your intestinal tract? It is, come on. You got, this is your intestine. You got 10 times more bacteria inside this intestinal tract than the number of cells in your body. Think about that for once. The only difference between this area that is full of all that bacteria and this area on the side of your body is going to be this layer of single epithelial cell. Okay? If these bacteria get down here into the tissue, you're going to develop septicemia, you're going to die. Not that simple, but you understand what I mean. The only pathway is going to be in here. If the iron is going to be absorbed, it has to come through this cell. From here, it has to come out here. Okay? There are mechanisms. When the iron level goes up in the blood, your liver produces a hormone called hepcidin. Hepcidin is going to break this part. It's going to stop this transfer of iron from the cells into the blood. Does anybody know what is the lifespan of these epithelial cells? Simple columnar epithelium. These cells. How long they're not going to stay there forever. 2 to 3 days. See how beautiful this metabolism of iron is? Because when you are having too much iron, your liver is going to detect that, it's going to produce a compound called hepcidin, and it's going to release it in the blood. Hepcidin is going to affect many cells. Actually, hepcidin is going to affect every cell that is going to allow the iron to move. Example, macrophages in the spleen. So what was the story? We talked about, the way that the red blood cell is going to be recycled, right? Macrophages in the spleen, they're going to be able to pick up the old red blood cells. They're going to break down the globin, the hemoglobin, the protein part of it into amino acids, right? They are going to go ahead and recycle the iron and send it to the bone marrow, right? So it's going to come out, it's going to be bound to a carrier protein, and it's going to be transferring, and it's going to be going to the bone marrow, right? If you have hepcidin, macrophages cannot let that come out. It's going to stay inside of the macrophages. What is going to be the outcome for your concentration of iron in your plasma, in your blood? It's going to go down. You understand that? It's going to go down. The average age for these cells, so they have to be replaced after 2 to 3 days. So if you prevent the iron from coming out, when they are cut off, or we call it sloughed off, they're going to go into feces, they're going to come out of the body. Guess how much you're going to lose on average per day? 1 to 2 milligrams per day. See how beautiful this mechanism is. You absorb 1 to 2 milligrams, and that's exactly what you're going to be losing. If there is a problem with this homeostasis, that's the disease state. That's when you are going to develop problems with iron overload or lack of iron. Okay? Questions? I told you about the functional iron. Ferrous iron is the functional iron. ferric iron is not functional. That's the way that we want it to be when the iron is going to be stored or be transported. Okay? Iron excess, we're going to talk about everything else in here. Oh, this is going to be, make sure that when you go home, some of you come and ask me, and I love it when you come and ask me this question. I just hope that when I give you an advice, I'll be able to help you. When you are looking, for example, at something like this, you've got to be able to tell a story. Many of you are perfect in memorizing what is this, what is this, what is that, but you cannot connect everything together. Everything's separate. You've got to learn to connect it. This is what the practical or critical thinking is going to be all about. You've got to be able to look at this image. You've got to be able to start telling me from food iron and how is it going to be transported to the bone marrow. Okay? If you be able to do that, then you have understood this perfectly and you're going to move on. This is going to be the iron in the intestines, the food that you have eaten. Okay? Meat is going to be the heme iron, or from the plant, you are going to have the free iron. But that free iron is going to be in what state? Ferric or ferrous? Ferric. It's going to be ferric. You don't have it in ferrous form. It is always going to be in ferric form when it's traveling because it's going to be oxidized quickly. It is going to be unprotected. However, there's a problem in here. That problem is going to be the fact that we cannot absorb ferric iron through these intestinal cells. We have to reduce it to the ferrous. We have an enzyme for that. That enzyme, is called it cytochrome B, but there's another name that I like more, and that's just my, not a big deal, it's just my preference because it tells me something. It's called, that's the same enzyme as that one, but this is more specific name. It is called vitamin C. Ferrireductase. Okay? Same as this one. But I like this one, because it tells me something. Later on, you might hear that vitamin C enhances the absorption of the iron. This is it. Because it's going to enhance the function of this. Okay? Enhances the function of this. So somebody like me, who is a vegetarian, how am I going to, so it's very important for you to know yourself well. Because I'm a vegetarian, I don't have any heme iron coming to my body. Everything is going to be non-heme iron from plant bases, right? So the question is that non-heme iron is not going to be absorbed as effectively. How can we go in and change the shift of balance in here? I will take a supplement of vitamin C every day, okay? Because that's going to enhance the function of this cell, so this cell would be able to go in and reduce the iron, and the iron is going to be ready. Did you understand why the plant iron is not going to be absorbed as efficiently as the heme iron? Because there is another extra step. If I ask you people, if I open this door and I open that door and I tell you, okay, go ahead and run around this building and come back sit in here in your chair. If I tell you that, okay, you do that and you gotta go stop in another room, open that door and go inside, then go ahead and finish it. When I put an extra step for you, it's gonna take you a longer time. It's not gonna be as efficient for the same reason. If you are having one extra step, it's going to affect the efficacy of absorption. All right? So you would be able to influence that. So when the iron is reduced by vitamin C, ferrireductase, then you would be able to absorb it through this channel. This channel is called DMT1. It's divalent metal transporter 1. Divalent. What is divalent? Anybody knows? Let me give you a few examples. This is a divalent ion. This is a divalent ion. This is a divalent ion. What do you have in common? That two, divalent. Okay, it's going to have two open spots in its orbit. So this channel, divalent metal transporter 1, is able to allow all this ion going through, but for focus is going to be in here in iron. Iron is going to be one of them. is going to go inside. Now what's going to happen when it goes inside? There are several things that may happen. One, it might be stored. Stored in what form? In a ferric form. Where? Inside of ferritin. Right? That's what we have here. Okay? So you would have enzymes that are going to reduce, they're going to oxidize this reduced iron, and they're going to store it in the ferritin. Okay? But if you need iron, you would be able to do something in here. And that would be that you would be able to send it. This is called apical surface, the surface toward the outside. This is called the basal surface, where the bottom, the basement membrane of the cells is going to be. On this side, you are going to have the blood. Okay? But iron cannot cross the membrane by itself. That's why we were not able to absorb it in here, and that's the exact reason we're not going to be able to let the iron go by itself out there to the blood. What you need a channel. You need a gate, and there is a gate for that. That gate is called ferroportin. Ferroportin. I really hope that you guys be able to connect these dots, because if you be able to connect these dots, I mean, science is really a beautiful thing. Because I'll give you one example. When we were talking about these gatekeepers and things like that, I told you that these gatekeepers are what? What kind of organic material? What are they?
Protein.
They're protein, right? And you all already know that proteins have their blueprint in the DNA. So you can make more protein, or you can make less protein. So because we are having this gate up here, that doesn't mean that this gate is always going to stay there. It means that if I want more of these gates, I can increase the expression of the gene. It means that if I want to reduce the number of these gates, I can inhibit the expression of the genes. These are not permanent things. These are not permanent features of the membrane. They come and they go. There's a turnaround, you know. They break down. They are going to be replaced by the new ones. Now, right now, the focus is that if the iron that's going to be in the ferrous state needs to go out to the blood, has to go through these ferroportin at the basal layer. Fine, it's going to go out. But I told you, you cannot have the iron be transported in a ferrous state. It's going to cause harm. What you're going to go ahead and have is that you got an enzyme in here. Hepastine. Hepastine is an enzyme that's going to oxidize the iron. It's going to oxidize the iron to Fe3+. And when it oxidizes the iron, now that iron can bind to the transferrin. And that's the time that the transferrin is going to be able to carry the iron all the way where it's supposed to go. Primarily, 75% of the iron is going to go to the bone marrow for red blood cell production. Okay? What if I have too much iron already in my blood? I have too much. I don't want any more iron. How? There are a bunch of things that's going to happen. So let me go ahead and tell you everything that I remember. I mean, if I be able to write it down, I can tell you all about it. But when I'm talking up here, sometimes I forget some of them. But again, if you guys read the book, you will be able to catch most of them. There are a couple things that are going to increase the production of hepcidin. Let me talk about this hepcidin up here. You remember hepcidin is going to do what? It's going to break down and inhibit this gatekeeper. If you don't have in here, what's going to happen? The iron cannot come out. It's going to be stored as the ferritin. And whenever this cell sheds up, you're going to get rid of that iron, extra iron. Everybody understands that? Okay. There are several things that are going to go ahead and cause hepcidin to go up. One of these is going to be the concentration of transferrin. If you have too much transferrin, that is going to increase the expression of the gene for the hepcidin in the liver. So you're going to increase the production of hepcidin. What's that going to do? Ferroportin is going to go down. What's that going to do? The iron cannot come out. What's that going to do? Iron is going to slough off and you're going to get rid of the extra iron without increasing the iron in your blood. Does that make sense? Everybody, questions? All right. That's one of them. So transferrin when it goes too high. There is another important case that I want to tell you about because I have seen that in board exams, so I want you to know about it. There is a gene, we call that, there are different names I have seen they use it, HFE gene, but I like the name hemochromatosis gene. The reason I like it is because, tell me something. When somebody tells me something, I like it. There's a disease. There's a disease called hereditary hemochromatosis. And that is when you're having a mutation in this gene. This gene controls in liver. It's going to control the production of hepcidin. Okay? So yes, if you have increased transferrin in the blood, you are going to be producing hepcidin. Okay? So hepcidin is going to bring the ferroportin down, so you're going to reduce it. But this gene, HFE gene, the hemochromatosis gene, is going to be much more effective. Anytime that people are going to go and have a mutation in this gene, they cannot produce the hepcidin. Because you would need this guy to produce the hepcidin. What do you think is going to happen to these people?
Iron toxicity.
Iron is going to be stored in their body. Iron is going to start stored in the ferritin, is going to fill up the ferritin. Another form of iron storage is going to be hemosiderin. Hemosiderin is going to fill up, then the iron starts being hanging out free without a problem. It's going to cause damage, oxidative stress. So I spoke to a friend of mine who is in San Diego, he's a cardiologist, and he said that, we were talking about this, and he said that, don't think that this is a rare case. He says 1 out of every 20 people with cardiac myopathy, they come to his office, they have overload of iron. They have had too much iron in it, so they have developed cardiac damage. Because whenever that iron starts accumulating in any part of your body, if it's going to accumulate in your pancreas, it's going to give you diabetes. If it accumulates in your heart, it's going to go ahead and give you cardiac myopathy, congestive heart failure. If it accumulates in your pituitary gland, it's going to screw up with your hormone productions. So it's going to be a bad thing. Hemochromatosis and transferrin concentration when they go up. Okay? Question?
Yeah, so that reduces hepcidin levels or increases?
No, it increases. Yeah. So if you have a mutation in this gene, you cannot make hepcidin. You cannot control production of the hepcidin. You don't make it. All right. Of course, again, remember this, to make the story whole, is that transferrin is going to have a transferrin receptor. Where do you think you're going to have the transferrin receptor the most? In marrow, in the red blood cell precursors. That's where you need it, right? You need it in there. So any cell that's going to go ahead and have the transferrin receptor is going to go ahead and bind to this one, and it's going to take in the iron, reduce the iron, and use it in whatever the purpose is going to be. Okay. So we understood overall picture what's going on in here. Now we are going back to anemia. I really don't memorize this thing, so let's try to make sense out of it. If you don't have anemia, if you do have anemia, are you going to be able to get enough oxygen into your body?
No.
So what do you think is going to affect? How is it going to affect you? What's going to happen to your breathing? Short of breath. What about, do you think that if you're short of breath and you cannot catch enough oxygen, do you think that it might cause hyperventilation? What do you think is going to do to your heartbeat? It's going to increase the heartbeat. So what is going to do to your temperature? It's going to decrease. That's why these people are always cold that are not having anemia. They're always cold. The color of the skin is going to be very white and pale. It's going to not have any color because the color, the redness that you see is going to come usually from the hemoglobin primarily. So you can see there are going to be a lot of, if you don't get enough blood to your brain, you're going to faint. You're going to get dizzy. All these, if your brain, central nervous system doesn't get enough oxygen, all these things make complete sense. And you would be able to understand how the anemia manifests itself. But remember, is anemia a disease? No, it's a symptom of diseases. There are many different causes that are going to give you anemia.
Why are they cold?
if they don't have high red blood cells, well, again, it all depends on what type of anemia we're talking about. Okay? They feel cold because of the fact that when you're not having enough red blood cells, the metabolism of the body is going to be reduced. Because remember, you have a lot of red blood cells, and those red blood cells, even though they don't have mitochondria, they're gonna, by glycolysis, they're gonna produce a lot of ATP, right? Think about that number is going to be reduced. Where is the heat of the body is gonna come from? Yes, muscles are gonna be primary, but it's gonna come from ATP generation, right? If you reduce the ATP generation, you're not gonna be able to generate as much heat, you're gonna feel cold. You're gonna be more susceptible to cold. Good question. Others? Okay, so you understand what's going on with the anemia, but you got to find out what the cause is. That's what we got to do in here. And these are the information that, 65-75% of the iron in your body is going to be in the hemoglobin. The rest of it is going to be ferritin, but you also have it in mitochondria. You also have it in myoglobin. We already talked about that. The source of iron, heme iron from meat, non-heme iron, and I already told you that which one is going to be more effective. Iron absorption and excretion, I think I covered that part as well in the image that we had. And same thing as this one, I have already covered this one as well. All right. I told you about transferrin. I told you about transferrin receptor. I told you about ferritin. I have not told you about iron response protein. IRP. IRP. I don't know if you guys are like me. If I understand something, I like it. If I don't understand something, I don't like it. Okay? That's why I don't like Trump. I don't understand it. IRP. I want you to understand how beautiful your body is. I want you to appreciate how magnificent this meat and flesh and bone is. Because IRP, this is the situation. If you are having too much iron in your blood, if you were in charge of your body and you would decide, you are having too much iron in your blood, so your transferrin is going to be high because it's carrying the iron. What would you like your ferritin to be? You want the ferritin to go down, right? So when you are having too much transferrin, you will also reduce your ferritin at the same time. One of them needs to go up and one of them go down. It happens in reality, they both happen at the same time, instantaneously. Everything that's going to go up and down happens at the same time. Why? How is that possible? This guy. This guy is going to be a protein that sits on the mRNA. You guys remember that mRNA? By the way, you guys are going to be the last class that whenever I teach this course again, I will not teach that lecture over cells and mitochondria and things like that. Because I have gone to a meeting and I realized nobody in the country does that. Everybody moves right into the hematology. I think I'm losing a lot of time there. So I'm not going to do it. But I hope that you guys remember something from that lecture about mRNA, right? When do we have mRNA? When you are synthesizing, you are transcribe the protein, the gene into the, mRNA. mRNA comes into the cytoplasm and is going to be translated in protein. So we got this mRNA, which means transferrin has mRNA, ferritin has mRNA, transferrin receptors has mRNA. All these proteins are going to have mRNA, right? This IRP has the capacity of sitting on this mRNA. For ferritin, it's going to prevent this one from being translated into protein. For example, the opposite action, you go and sit on the mRNA for the transferrin, you're going to increase the translation of this one. Same protein is going to have different effect on different mRNA. That's the way you're able to increase, for example, the transferrin while you're decreasing the ferritin, or vice versa. It's going to happen exactly the same thing, but the opposite direction as well. You would be able to control a bunch of different variables at the same time. And that's really the key for having such a tight control over the iron in the body. We have already talked about that one. We already talked about transferrin receptors. If your iron goes down in your blood, less than normal amount, what's going to happen here is that you are going to increase the amount of transferrin production. That's the trigger in the root. By the way, transferrin is produced in the liver. Liver produces transferrin. So if your iron goes down in the blood, liver is going to detect that, is going to increase the expression of the gene for the transferrin. But it's also going to increase the gene, as I told you with IRP, it's going to increase the production of the transferrin receptor as well. So the cells are going to have more transferrin receptor, and the blood is going to have more transferrin in it. Okay? I'm going to introduce new concepts in here, so make sure that you understand what I'm talking about. Apoferritin, I told you, is going to be the ferritin without the iron. It's a precursor to the ferritin that's going to have the iron. That's the way that you store it. But there is another way that we're going to be able to store the iron. This is going to be the oxidized form. It's going to be hemosiderin, and is not as effectively going to be, you cannot remove the iron as effectively from the hemosiderin compared to the apoferritin. You cannot do that. Okay? You can. If you're really desperate for iron, you would very ineffectively get iron from this. Okay? But this is much easier and more effective in order to get the iron. So you got these stores. Whenever you have extra iron, first is going to be filled as into the ferritin. As ferritin is going to be full, gradually becomes more and more, then you would be able to convert the extra iron into hemosiderin. Okay? One more thing in here. Then I want to tell you about. That's it. Okay. Couple of things. Serum iron is going to be diurnal, so you will have different concentration throughout the day. So if you really want to go ahead and know what is the best, the actual concentration of the blood iron for a person, the morning specimen, fasting morning specimen is the best specimen. Remember that. Fasting morning specimen. First morning specimen is going to be drawing the blood, measure the iron is going to be the best method. Because as you go throughout the day, you are going to go and have a lot of things happening to your body. Now, you're going to have your iron going down, you're going to have increased hemolysis. Every time that you are stepping on this leg and walking around, or you're playing football, you're going to have these red blood cells rupture left and right inside your body. So a lot of things are going to happen. If you want to measure the iron, you got to measure it in the morning when it's fasting. You understand why the diet is going to go ahead and affect it, right? I want to introduce you a few terms in here, and you need to understand them because they're very simple, but they also can be very confusing. Number one is going to be total iron binding capacity. Short abbreviation would be TIBC. Okay? What is TIBC? In order to understand TIBC, I'm going to draw a diagram for you on the board. You guys back there, Neil, you guys can see up here? Is okay? Yeah? Juliana, you can see up here or no?
Not really.
No? Okay, that's all right. Thank you, Vinny. Perfect. See? Perfect. You just have to adapt to the environment, you know? I cannot turn it up, so this is the best way. Okay, what we were talking about here, TIBC. I want to explain to you what TIBC is. Pay attention because I will promise you I will give you questions on this. This is your blood, okay? These big balls are going to be transferrin. I'll put the T in them so you know that we're talking about transferrin, okay? And the smaller, I saw color. Oh yeah, beautiful. So these are going to be the small one are going to be the ferric iron. Simple so far. Two things I want you to pay attention. Number one, first of all, not every transferring molecule is carrying iron. Okay? Not every one of them is carrying iron. Something around 40 to 50%, sometimes less, sometimes more is going to be the normal thing. Another thing, you don't have 2 irons in every transferring. Maybe one of the sites is going to be filled and not both of them are going to be filled. Okay? What is total iron binding capacity? It means the entire ability of this transferring to be filled. So if you are going to have every one of these places filled, the total iron binding capacity is going to be 100% because every place is going to be filled. But in reality, that's not the case. You're not going to be able to fill everywhere. We already know one thing in here so far, and that thing is going to be this. You are not going to have free iron traveling in the blood, right? So if I measure the iron in the blood, what am I actually measuring? I am measuring the transferring and the iron that is attached to the transferring. Okay? So you are going to have the serum iron is same as what? It's same as iron that is attached to the transferring. You're not measuring the total transferring. Be careful in here. You only are counting the one that has the iron. You don't count these guys. Okay? So what's going to happen is that the next term that you need to know is going to be this. Transferring saturation. Is a formula. You are going to go get the serum iron. You measure that. You're going to calculate that transferring saturation. It's going to give you information so you will be able to determine why you have the anemia. That's the key. We're going to determine why the anemia is being caused. What is the cause of the anemia? You divide it by TIBC. That's going to be the total transferring, okay, total iron bonding capacity, times 100 is going to give you transferring saturation, okay, percent. And that's going to be important. If you are going to have a transferring saturation going above 60-70%, that's going to have one indication. And if you are having it below what's supposed to be about 25%, is going to have another story. Don't lose perspective. We are going to talk about anemia from now on for a long time. So when it comes, when I tell you that the transferring saturation is going to be above the 70%, I want everybody to understand what I'm talking about. Otherwise, you're going to be lost. You're not going to understand what I'm talking about if you don't understand what TIBC is, what transferring saturating is, or UIBC. Another one of these things is going to be UIBC. What is UIBC? Unsaturated binding. What is UIBC do you think it is? These guys that are not, for example, attached to the iron. These are going to go ahead and make the UIBC, unsaturated bonding capacity for the transferring. So those that are not connected or bound to the iron are going to make the UIBC. So TIBC minus UIBC is going to give you what? It's going to give you the serum iron. Did you hear that? TIBC is what? Everything. Right? UIBC are the ones that are not connected to the iron. So this one. And that's going to be what? Iron concentration. Remember, anytime that you measure the iron, you're measuring transferring that is attached to the iron. So it's going to give you this one. So I can give you one information you would be able to get the other information in order to determine what's the matter with the person. All right? Okay. Let me see. I don't want to. I told you about the plasma ferritin. Okay. Since we have the screen up, I want to do something else before I put the screen down, so I don't want to make Vinny go up and down throughout the class. We used to have a teacher, and she was wonderful. I mean, but every 20 minutes she would tell, okay, everybody go stand up on your chair. And we would go stand up on your chair and say, okay, raise your hand, do this, sit down. And she would start talking again. 20 minutes later, go stand on your chair. Because she didn't want to fall asleep, so that's what she was doing.
It's effective.
Yeah, it was effective, yeah.
Teaching or torturing?
What's that?
For teaching or torturing?
Yeah, teaching is torturing, anyhow. It depends on who's on the other side. I want to tell you a little bit about anemia. I'm moving to the next picture because I want to bring the screen and we go over everything because it's a related topic, so it's not going to be a problem. So anemia is reduction in red blood cells, hemoglobin, and hematocrit. All connected. You understand that part, that much so far. So what we need to go ahead and talk about is the types of anemia because we have many, many different types of anemia, and we will cover most of them throughout this course. However, anytime that you come across anemia, you got to ask yourself, how would you come across anemia, first of all? How would you suspect somebody has anemia? Tell me one more time.
Low red blood cell.
You do a CBC, you see a red blood cell is low, you see the hemoglobin is low, you see the hematocrit is low, that's what I mean. The person has anemia. But what is causing the anemia? That's what we are trying to find out. You got to ask yourself this question. Is the anemia due to increased destruction? Or is it due to decreased production of red blood cells? Why is it? Am I producing the red blood cells and they break apart for whatever the reason is? Or I am not able to produce the red blood cells because I cannot make the hemoglobin. There's something wrong. I cannot make the hemoglobin. Okay? That's the first question that you need to ask when you are coming across an anemia. Any case study I gave you, this is the approach that you follow. How would I be able to know whether or not it's going to be increased destruction or decreased production? What would be a test that you already been exposed to and you would be able to use to determine what's going to be the answer? Anybody? No. What was that? I heard it. Retic count. Reticulocytes. If you are going to go ahead and have decreased production of red blood cells, what would you expect your retic count to be? High or low?
High. Should be lower.
If you have decreased production, your retic count is going to be low. It's going to be usually less than 3%. Think about it. If you cannot produce red blood cells, what is retic? What is a reticulocyte? It's a fresh new red blood cells. If you cannot make enough of them, what's going to happen to this? Your retic count is going to be lower. If this is the cause of anemia. Okay? Now, if you are going to go ahead and have a retic count that's going to be way above 3%, okay, then you would have increased destruction, which means you're losing the red blood cells. Your bone marrow realizes that you are losing the red blood cells. That's why it tries to compensate, kicks out more reticulocytes into the circulation. Does that make sense to everybody? Mm-hmm. If anybody has anemia, ask yourself this question first. Is it because increased destruction or is it because decreased production? How would I be able to determine that? I would do a reticulocyte count. You got the reticulocyte that is going to be low, decreased production. You're going to have a reticulocyte that's going to be high, it's going to be increased production. Pretty straightforward, right? Now, anytime that you are going to have decreased production The next best step that you would be able to use that I like it. You see different books, different people describe it differently. But this is the way that I like it the most because it's very straightforward. Anytime that you are on this side of the alley, next thing that you're going to look for is going to be MCV. Okay? By the way, before I forget, I want to tell you one thing. I am very impressed with the accuracy of your laboratory assessments. When you are doing lab reports, your numbers, you should be proud of yourself. I mean, you guys are doing things with the hemocytometer that I can tell you that many people cannot do. You are very close, but you are very careless when it comes to the units. You are very careless when you are putting the numbers down. But you're doing the hard part, but the easy part you are being very careless. So please pay attention because you're losing a lot of points for no reason. Because you did the hard part, but you're not doing the units, you forget to put it, or you put volume instead of area and things like that. And there is no reason to lose point over this kind of thing. Sorry for distraction, but I just want to tell you that. MCV is the next thing you're going to look at. Now, what is going to be the normal range for MCV? That's one of those things you need to know by heart. 80 to 100. So if it's going to be above 100, or it's going to be 80 to 100, or is it going to be less than 80? Okay? If you are going to go in and have MCV above 100, you are going to have macrocytic anemia. Okay? If you are going to have below 80, you're going to have microcytic anemia. And if you are within the normal range, you are going to have normocytic anemia. Okay? You have normocytic anemia. If you are going to go ahead and have macrocytic anemia, it's going to primarily do one thing. Remember that. If you are, so I have anemia patient, I look at the retic count, pushes me toward the decreased production, then I look at the MCV in the CBC result, and I see that the person has an MCV of 120. Okay? So I'm going to go ahead and call it microcytic anemia right now, but we're going to find out why you are having that anemia. It's always going to be due to decrease in DNA precursors. I want to tell you a secret. Probably you are the only one in your family who's going to know that secret, except for Jonathan. His brother knows it. And that secret is this. If you are wondering why these red blood cells are so big, you're going to ask these questions. Why is it so big? Why did they become so large? It's because there's a problem with DNA production. When they cannot produce the DNA, the cells cannot divide. So they get bigger and bigger and bigger. And that's why they are going to be macrocytic. We will talk about what causes it exactly when we come to this discussion. We're going to talk about, we're going to have a lecture just about this one later on. But I want you to understand, anytime you're going to have a macrocytic anemia is due to problems with the DNA production. Anytime that you are going to have microcytic anemia is due to hemoglobin production. Okay guys, can I go ahead and, what should I do? Erase it. I'm going to erase this part. Everybody okay? And I'm going to go ahead and write about macrocytic on this part. Okay? So microcytic anemia is going to be due to what? Hemoglobin production. I have forgotten. Can somebody help me out in here? What is What are the main components of hemoglobin? Heme and globin. What was the main part of
Iron.
iron and protoporphyrin? Thank you very much. And the globin in adults, you already know that. What are the main hemoglobin molecules in an adult? The alpha and beta. Let's take a step back. I just want to make sure that everybody's with me. I have a patient with anemia. The first thing I look at is what? I have a patient with anemia. The first result that I'm interested to know is what? Retic count. The retic count is going to tell me whether or not I'm increasing destruction of red blood cells. I'm decreasing the production of red blood cells. Then, after I came to a decreased production of red blood cells, I am going to go ahead and look at another value. What is that value? MCV. If the MCV is going to be above normal, is macrocytic anemia is primarily due to what? DNA problems. If you are going to have the MCV below normal, you are going to have macrocytic anemia primarily due to what? Hemoglobin production. Hemoglobin consists of two main components, heme and globin. Heme is going to consist of two main components, iron and protoporphyrin. If the problem is going to be because of the iron, you got iron deficiency and anemia. If you have the problem because of the protoporphyrin, it's going to be sideroblastic anemia. I will tell you what sideroblast is. It's not a big deal. It's just a cell with iron in it. That's it. Okay? If you are having the problem because of the problem with the globins, you got thalassemias. Okay? See how many different anemias you're learning now? Now, of course, we know that, and we will talk about this one. If you are going to have a problem with alpha globin, you're going to have alpha thalassemia. If you're having a problem with beta globin, you're going to have beta thalassemia. And each one of them is going to be divided in subcategories. But we understand the big picture so far. Okay? If you are having your MCV between 80 to 100, but the person is anemic, the primary thing is going to be that, again, you got to make sure that you're already looked at the retic, so we know that is going to be decreased production. It's going to be primarily due to decreased cell division. I'll give you one example and I'll come back to it later on. There is an anemia, we call it aplastic anemia. When you look at aplastic anemia blood smear, guess what you're going to find? You're going to find everything is normal. You just have fewer number of cells. And different people have different reasons. But they all have one thing in common. And that is that the stem cell, hematopoietic stem cell that we talked about a long time ago, is supposed to divide at certain rate. That rate has been reduced for whatever the reason is. For some people comes and goes. For some people comes and kills them. Okay? We don't know exactly, depends on the individual what the reason is, but there are a lot of pollutants in environment that can cause aplastic anemia. Okay? So what's going to happen, there are going to be smaller number of divisions of those hematopoietic stem cells, so you don't produce enough cells. But those cells that you produce, they all got the right hemoglobin, they all got the right size, you just don't have enough of them. Okay? Alright. Now, since we have the board up, let me go ahead and tell you, and these are the things that I'm going to tell you, we're going to cover in 3 weeks. I'm telling you the lecture for 3 weeks so far. But if you get a big picture, then we're going to go ahead and explore each one of them individually. And we're going to get into deep discussion about them. Okay? Increased destruction. That's why I was telling you iron saturation is going to be important, transferrin saturation is going to be important. All these values that I'm telling you, TIBC are going to be important. Because you got to be able to work this out. If you are having increased destruction, it's going to be due to 2 different general classes of problems. Let's call them intrinsic and extrinsic. Intrinsic, I like to call them apathies. I'm sorry, intrinsic, I like to call them apathies. And understand why I'm calling it apathies. Because the problem is going to be enzymopathy. Enzymopathy. You already know this one. G6PD deficiency. Okay? We're going to have membranopathies. Okay? Like, you know this one too. Hereditary spherocytosis. Enzyme, and we got the last one. Hemoglobinopathies. Such as sickle cell. Such as sickle cell. Can anybody tell me why I did not put the hemoglobinopathies like sickle cell someplace down in here, on this side of the board? Give me a quick answer. Why? What do you think is going to be the reticent of a sickle cell patient? It's going to be elevated. The problem is not that you're going to not produce the red blood cells. The problem is because you're producing a lot of them, but they die after they come out. So retic is going to be high. So they're not supposed to be on this side. They're supposed to be on the side that you're going to have high retic. Okay? That's what I mean that you got to understand the entire picture in here. Okay? These are the three apathies. Okay? And the one that's going to be extrinsic are going to be divided into two groups. Immune-mediated and non-immune mediated. Immune mediated. If the mother is Rh negative and the fetus is Rh positive, and at the time, there is some of the baby's blood gets into the mother's blood system, mother is not going to recognize that D antigen, that Rh antigen, is going to make an antibody against it. Did we talk about that before or no? Yeah. Have we talked about this in the class or no?
No.
Oh. Okay. Well, I'll come and tell you about it when I'm discussing. I'm going to come back to each one of these topics. So, because if I want to tell you right now, then it's going to take a lot of time. So we're going to come back to it. But be aware of it. If the mother is going to, so this is mother's blood. This is baby's blood. Baby is Rh positive. Let's say O positive. And the mother is O negative. When you are positive, it means you got an antigen called D antigen. You may know it as Rh factor on top of it. Let's say this is Rh factor antigen on the surface of the red blood cell. Okay? If this red blood cell gets into the mother's system, the mother doesn't recognize this. It thinks it's a foreign antigen. It's going to go ahead and make anti-D. Okay? Anti-D is going to attack the baby's red blood cell, is going to destroy it. Gives anemia, right? Immune-mediated. That's going to be immune-mediated. Example of immune-mediated. Non-immune-mediated. What about malaria? Right? Malaria, parasites, things like that is going to be, or you're having GI bleed. You're losing blood. Okay? Is going to be that. You saw this big picture. Okay? So let's now go to the screen and make sure that we cover everything that we have about. Vinny, could you please? Thank you. All right. Put the string on it, huh? All right, I told you about this one. Let me see. Serum transferrin receptor. I told you that anytime that the transferrin goes up, anytime that the iron in the body is down, transferrin levels is going to go up, but so is the receptors for the transferrin. because eventually some of these receptors from the membrane are going to go and spill into the blood, and you would be able to go and measure it. The test for the serum transferrin is one of newer tests. When I was working a decade ago, 15 years ago, we didn't have that test. This is new. And that's really going to go in and help to know whether or not what's the status of the body. And I will tell you when we come to the disease. Free erythrocyte protoporphyrin. So what is free erythrocyte protoporphyrin is going to be this. If you are going to go ahead and make heme, you will need iron and protoporphyrin. Everybody knows that, okay? However, if you are not going to have enough iron, you're not going to be able to make protoporphyrin, okay? And the protoporphyrin is going to be breakdown, is going to become porphyria, compounds related protoporphyrin. Unfortunately, it's not going to become bilirubin. It's not going to be bilirubin. It's going to be other compounds, but related to the same thing, okay? If you are going to be able to measure the free erythrocyte, it's going to tell you one thing, protoporphyrin. It's going to tell you there is an imbalance between amount of iron and protoporphyrin. If you are not going to have enough iron to put it in the protoporphyrin, you're not going to be able to make the heme. Isn't that was one of the causes of having the anemia, when you cannot make the hemoglobin? Wouldn't that be fit the category? So it is very important to have the balance in here. Okay? You have the balance in here. And that's what this test is going to be here. Tissue iron. This is the stain that you should know. I think that this stain, I have seen it on board exams, So, and it's still being used too. It's being used in laboratories, more specialized laboratories. So you want to know, you don't understand what's the matter with this person. There are many times that if you don't find any answer for it, the easy way, you got to do bone marrow biopsy. You got to do bone marrow aspiration to find out the answer. And one of the tests that you would be able to do is Prussian blue. Is a stain. And when you do the Prussian blue, you would be able to stain the iron inside of the mitochondria or the free inside of cytoplasm, and you would be able to see how much iron is going to be present. Now, I don't remember exact the ratio of the number of cells that are going to have the irons versus those that don't have irons, but there is a specific ratio, 5%, 10%, something like that. As you're seeing that more cells are going to have iron in them, it's going to indicate iron overload. You are having too much iron. As you're having less cells are having iron, you're going to indicate, that's going to indicate iron deficiency. But you would be able to do Prussian blue in order to determine the iron in the tissue. So if you are having, for example, the biopsy of your pancreas and they do it, stain for the Prussian blue, you see there is a lot of iron deposit, that explains the problem of the disease. You have iron overload that causes the pancreatic failure. Same thing with the heart. You're going to have iron overload that's going to cause cardiac myopathy. Okay? So Prussian blue is very important for iron. Iron excess is going to cause a lot of disease. Anywhere in your body that iron accumulates over time. This is not something, that's why we don't see iron overload in very young people. We usually see iron overload among people 50s and above. That's the time but it didn't start yesterday. It started very early on and accumulated over time. So you can see all those different diseases that are being caused by the excess amount of iron in the tissue. Okay, let's go to the next lecture. Now this is a lecture about anemia. And I told you most of the things I want to tell you. So we can go over this one very quickly. We understand the definition of the anemia, low red blood cells, which is going to be translated into low hemoglobin and hematocrit. That's what the concept is going to be. The values that are going to be decreased, of course, you are going to have decreased red RBC count, decreased hemoglobin count, decreased hematocrit count. The problems, we talked about that. Variation in normal references. You cannot expect everybody to have the same amount of blood in their body. You see, I said in the beginning of the class, you got to see who's on the other side. So you would have a different range of the red blood cell count, hematocrit or hemoglobin count for a female than a male. Because that's going to be a direct result of the amount of the muscle you have. If somebody has more muscle mass, they're going to have higher hemoglobin. If you have less muscle mass, you're going to have lower. Overall, in general, males have more muscle mass than females. Okay, that's why they are going to have a higher rate. When you're looking at the ranges for this, for example, hemoglobin for the male and the female is different. Females is going to be a little lower. It's just because they have less muscle mass. That's it, nothing else. Okay, or if you're looking at a kid versus an adult, you cannot use the same range. It's going to be very important to realize who you're looking at. Okay, so that's what I mean by the reference ranges. Different people have different reference ranges. Even among different ethnicities, it's going to vary. Okay? So you got to always take that into consideration. Don't be surprised if you're working in this hospital, they have one range. You go across the country, another hospital, they're going to have a different range. Because of that factor, they have already studied that. Okay? Clinical findings. We have already talked about that one, but I think that you guys are going to be fine, and you would be able to work your way out to understand why anemia can cause any one of these different problems. You already know about the red blood cell size and characteristics. I'm not going to get to it, but I want to tell you about two things. You can have ineffective erythropoiesis. You can have insufficient erythropoiesis. What is the difference? In this case, ineffective. You are making the red blood cells. You are making the hemoglobin. But that hemoglobin, for whatever the reason is no good. Like sickle cell. Like hemoglobin C. Like hemoglobin E. Like the case of thalassemias. You do make everything that you're supposed to. They're just not going to be good. Okay? Ineffective. Insufficient. Like iron deficiency. You don't have enough to make. You cannot make enough. Rather than you making enough, they just break down. You cannot make enough. That's going to be insufficient erythropoiesis. They're different. And of course, another reason for the mechanism of anemia is going to be blood loss. Number one reason of anemia in this country, you know what it is? GI tract. No, GI tract bleeding. GI tract bleeding is not something that is going to be just happening in old people. If you go to your dentist and you remove your wisdom teeth, of course you're not going to feel like eating. But it's going to hurt so bad. What do they give you? They give you 800 milligram ibuprofen. If you're going to go ahead and take that ibuprofen on an empty stomach, you will have GI bleeding in 3 days. Okay? That's what I'm talking about. Okay? Menstruation, females that are going to be menstruated. What, question? Huh?
Why is it when you have like internal bleeding that way, they say that your stool's supposed to be black when there's other bleeding?
Because
going on?
okay, so if you're having red, in your stool, that's going to be lower GI. Okay, but if it's up, that redness is going to turn into black because that iron is oxidized. By the time it's going to get down here, that hemoglobin is released and has been oxidized and changes the color.
And it can't be recycled and reabsorbed like with the bilirubin?
You will absorb it actually, some of it, but when it's too much, it's going to go through.
Okay.
But you will absorb it. Actually, one of the things that happens is that you will absorb some of it, and we will discuss that later on. Is going to go ahead and affect different variables. But the bottom line is that when you are having so much, in the case of the GI bleeding, which you are bleeding, it's going to go through. Some of it is going to go through. It's going to cause the stool to turn black.
Will it still have the increased bilirubin?
That's yeah. Not increase. Depends on what is. In the case of GI bleeding, no. But you will have increase in something else.
Okay.
Urobilinogen you will have increase. Think about that. You're in my UA class, aren't you?
No.
You're not. Oh, okay. That's fine. But you will have increase in another compound called urobilinogen because that bilirubin is going to be broken down into urobilinogen, and because you are releasing a lot of blood in your GI system, that urobilinogen is going to be absorbed into your blood, is going to be cleared by your kidney, is going to come out of the urine, so you're going to have increased urobilinogen.
Okay.
Yeah. See, everything is connected. Everything works together. Yeah, exactly. All right. But you're going to have the blood loss is another way that you're going to have a mechanism of anemia. You got to find out why you're having the blood loss, whatever the reason is going to be. I already told you, CBC and reticulans are still going to be the most important way for us to be able to get the preliminary information to establish a diagnosis for anemia. Sometimes, most of the time, they're going to be helping us to determine what's going on. If they don't, the next golden mark is going to be bone marrow biopsy and aspiration. When you are looking at this two slides, you would be able to go ahead and come up with quick ideas what's going on. What is the problem with this one? Can anybody describe a problem with this slide on this side? No, I would not call that hypochromic. Not at all. I would call that, maybe perhaps it looks from this angle, I don't have a lymphocyte to compare it, slightly maybe macrocytic, but it's not hypochromic. I call this hypochromia. Okay? I look at this one hypochromic. So when you are doing this CBC, you want to be able to look at all these different variables. If it doesn't help you to find out what's going on with the retic count, you got to go ahead and do the bone marrow biopsies. And I think I explained this on the board for you folks, the importance of the MCV, how it's going to be translated into various diseases, okay? All right, I am saying it for the last time in this class, because I do understand and I didn't take off points from anybody, so don't think I took a point from you on your lab reports. When you are seeing hyperchromic, there is nothing, you never see a report that the red blood cell is hyperchromic. I understand what you're saying, okay? Because you are seeing the MCH and MCHC are elevated, so you say hyperchromic, but I want you to put a little bit thought behind that concept. If you are going to have elevated MCHC, I mean, what is anemia? Reduction in that value. So you're not going to have hyperchromic. So the idea is that you can have macrocytic, microcytic, normocytic. You can have macrocytic hypochromic. You can have macrocytic normochromic, or you can have normocytic normochromic. But you are not going to have either one of these on the first, followed by hyperchromic. What that hyperchromia, I'm not saying there is no such a thing. The word is accurate, but the concept is not right. The concept is that when you are having MCH is going to go up, MCH is going up, there is two things that are possible. Two things that are going to be possible. What is the normal range for MCHC? I'm going to use that one as an example in here. MCHC usually runs about 32 to 36. Okay? Now what I am going to have in here is that, let's say my MCHC is going to be 37. How would I be able to interpret that? You would be able to see that often. So what that tells me that is the concentration around inside this hemoglobin, inside these red blood cells for hemoglobin is very high. The hemoglobin viscosity is high. Usually that's the case that the red blood cell loses its membrane, but it doesn't lose its volume. So you will have the same number of hemoglobin molecules in a smaller area. So what's going to happen here is that the hemoglobin viscosity is going to go up. MCHC is going to indicate that. It's going to indicate that, hey, it's elevated because the red blood cells probably are spherocytes. You're going to have a lot of spherocytes there, for instance. That's one possibility. Okay? Don't be surprised if you are having somebody with hereditary spherocytosis to have MCHC of 38. It's quite likely that's going to be the result. But another thing is that you cannot just go based on that. You got to always think about your decisions. If I see MCHC of 45, immediately I'm knowing that there is something fishy in here. This is not right. I will never report something like that. Okay? Now, what is going to be right or wrong is very simple to find out. This is going to be case of hemolysis. Very likely a specific type of hemolysis that you're going to learn later on is called intravascular hemolysis. MCHC is what? Hemoglobin divided by hematocrit times 100. If you are having the red blood cells have ruptured inside your blood vessels, they have lysed, they have hemolyzed. When you are measuring the hemoglobin, remember this, when you are measuring the hemoglobin in the blood, you are measuring the hemoglobin inside of the red blood cells and the free hemoglobin. In a healthy person, Majority of that hemoglobin is inside of the red blood cells. But for whatever the reason is, that hemoglobin is going to be out of the red blood cells because the red blood cells have ruptured. But you measuring it, you're going to get the same number, right? Let's say, I don't know, 15 in here. Based on the rule of 3, what would be your expectation in this person's hematocrit to be? 45. But you are going to, are you going to have 45 hematocrit?
No.
If your red blood cells have ruptured, are you going to have a what is hematocrit? Packed red blood cells. If they have ruptured, they're not going to pack, right? So what's going to happen? Hematocrit is not going to be 45. It's going to go down 30. What is that going to do? It's going to increase your NCHC. It's going to give you something around 45. Okay? So that is indication when your NCHC is very high, it's going to indicate intravascular hemolysis. Okay? This is the way that you cannot just shut down the brain when you go to work. You always got to think about the results coming out to make sure that the machine is doing the right thing. This is a very good chart. It's fine. If you want to use this one versus the one that I drew on the board, fine. Same thing. It's just a little bit different approach. In here, they go first with MCV. Then they use the retique to separate the concepts. Okay? I like the retique because the way that I explained it to you, I like that. But this is fine too. There's nothing wrong with that one as well. Okay. Evaluation of anemia. What is RDW? Red blood cell distribution width. Remember, RDW is like it's like hyperchromic story. You can have normal RDW. You can have elevated RDW. You cannot have decreased RDW. You don't have such thing. Okay? Because RDW is going to go ahead and tell you what? It's going to tell you the average difference in sizes of red blood cell. Okay? Another word for it is going to tell you about anisocytosis. Anisocytosis. Okay? Now, when we are learning about anemia, such as the iron deficiency anemia, you're going to realize that things are not going to happen instantaneously. You're not going to overnight become iron deficient. Usually it's a progress. Okay? There are stages. There are phases. I am a person that is right now prone to iron deficiency. Let's say that. But something happened. I'm having GI bleeding. I'm having some problem that's happening right now. It started now. I am not going to become iron deficient for a while. Okay? Because of the fact that I have enough ferritin, I have enough hemosiderin, I have enough iron stores, mechanisms through my food to absorb as much as I'm going to be able to do in order to make sure that everything goes fine. But because overall the net amount of iron is going down, over time I start showing the symptoms, okay, for iron deficiency. All right? There are 3 things. Oh, okay. RDW. So if that's going to be the case, the average life of a red blood cell is going to be 120 days, right? So what's going to happen is that when you are going to be iron deficient, then iron deficiency starts to kicking in. Your red blood cells are going to be microcytic, right? Yeah. Their size are going to be smaller. But those red blood cells that had enough iron in the beginning, they are going to be normal red blood cell size, right? What's going to happen to RDW?
Bigger,
It's going to get bigger. Okay? It's going to get larger. So that's the way that you would be able to use RDW. It's talking about the different populations of red blood cells. You know another person that's going to have RDW increase? Sometimes I see it in transfusion people. People who are getting transfusions, blood transfusion. Get somebody's blood, and because they have illness, they are going to be microcytic themselves. The new blood is going to be normocytic. You're going to be able to have RDW increase. So be aware of that kind of things as well. But there are basically 3 possible pathways. Decreased production, we already talked about that one. Increased destruction, we already talked about that one. And increased blood loss, GI tract bleeding, example I gave you, we already talked about that one as well. Now, the next one is going to be also, I like these lectures because these lectures are connected to each other. They're the same topic. They're the same topic, but different aspect of it. And I'm doing all this because of Merrill, where are you? I'm just doing it because of you told me that. No, we will fall behind. But this is very simple. These ideas are going to be just flow into one another, and I think it would be better to get them at the same time rather than separately. Now we are talking about one of those anemias, and this is what we're going to do for the next few weeks. We're going to talk about each one of these different types of anemias. Now we are going to go ahead and talk about iron deficiency anemias, or problems associated with iron metabolism. Let's just, okay. As I told you, there can be many reasons for us not to have sufficient amount of iron. And it makes complete sense when you think about it. If you don't have in your diet, if you don't have iron in your diet, of course your level of the iron is going to go down over time. Okay? Increased need. A pregnant mother, breastfeeding, menstruation, all those factors. Chronic loss, GI bleeding. Does anybody want to go bathroom? Okay, why don't we hold 5 minutes, people? Go on. I see that everybody's going, so I guess that's a sign that I should stop. Okay, let me hold on.